Hopefully nothing too difficult. It's really about your experience and what it's like to relate with patients who are in chronic pain, because this constant sense of suffering and having no actual cure in sight, but like learning how to manage and how you would deal with frustrations and just questions like that. So there are no right or wrong questions or answers. And it's really just to get an idea of what it's like to be on the treating side, because I'm also going to be interviewing patients to see what it's like to be on the receiving side too. So.
Sure.
Just to start off, could you tell me a little bit about how you chose to become a chiropractic doctor?
Sure. I always wanted to be a doctor. When I was a kid, I was with a pediatrician, Dr. Aaron Reich, who diagnosed the very rare anemia that I had.
Oh.
And so I was really encouraged by that, and he was kind of a hero.
Wow.
So I thought, well, that'd be really great if I could do something like that. So as I went on in school, I studied some different things, but didn't quite make it to med school, wasn't really interested, but still wanted to help people. When I was 17, I had a back injury, and then went to numerous doctors, no help, many therapists, no help, and then my dad took me to a chiropractor, and that was the thing that changed it for me. So I was really encouraged by that. I was in pain probably for about a good 10 months or so.
Wow.
At 17, 18 years old, it was a challenge for me to deal with.
Mm-hmm.
So it was really helpful when I finally went to go see the doc. And the doctor was a chiropractor. So I thought, well, this is a good idea, to help people physically. I'd always been physically active, and I thought it was a good fit.
So you kind of know what it's like to be a patient.
Frankly, it's taught me a great amount of empathy. It's easier for me to empathize with patients who have pain than someone who's never dealt with, not being able to get out of bed, or not being able to, bear weight on a leg or something like that.
Do you think that empathy played a difference in your care also? You had mentioned that you had been to several different therapists and doctors also, but it was a chiropractor that made a difference. So if you could remember, what was it about that experience that made such a significant impact on you?
The prior experiences of not getting help, or the
I guess maybe in contrast, or those are connected.
Question. Sure. I think there were a lot of dead ends. I think that a lot of the people that we had seen, I remember, I was younger and wasn't necessarily paying attention, but I remember them saying, like, well, there's nothing else we can do.
Oh.
And it just was discouraging. And I guess what really, the one thing that really helped was that it was more hands-on.
Mm-hmm.
And I got results from the treatment.
Mm-hmm.
And I don't remember anything that the doctor said. It was Dr. Rose. And, when she was talking about it, I don't remember her saying anything that was like magical or anything that convinced me or anything like that. I was just sort of like waiting, for something to happen. And then she worked on me for a little bit, and things definitely got better.
Wow, that's a pretty neat story. Do you talk about that experience with your patients or new patients? Or?
I don't. I'm
Mm-hmm.
pretty focused on them.
Okay.
Sometimes I think if people have a condition and they've got lots of questions, and then I might go into it. I might talk to them about that. But I try not to share too much.
Sure.
I do from time to time.
Well, that's a pretty neat story to start off with. So do you have many chronic pain patients here, or are they mostly injury, or what would you say?
Well, most of the conditions we see are chronic, musculoskeletal things. We do have some acute pain patients, but they're rare in this location. So if people are acutely injured, they don't come to work, and this is primarily a work employment location.
Oh, I see. So what percentage of our practice would you say are chronic pain patients?
About 60%.
Okay. And how long have you been working as a physician here? Or not just here, but I guess how long have you been practicing?
Sure. I graduated in April of 1998, and then was board certified right after that.
Oh, you went straight in.
And started in August. So I've been practicing since August of 98.
Okay, wow.
Yeah.
So
and then after that, I did another degree in orthopedics. So I have an orthopedics diplomate and a fellowship in orthopedics.
Wow.
So that helps with the patients as well.
I see. So what is it like to work with chronic pain patients?
Well, it can be really frustrating, but it can also be very rewarding for the patient. I think the same thing that happened with me is I think the hands-on aspect is really important. And I think that's something really unique to what we offer, is that it's hands-on. And I think that people who have an association or a connection psychologically to their pain, when you have your hands on the patient, it does change that perception of, you know, a certain tissue injury, say a soft tissue injury, is painful for a period of time. That what we find is that there's a neurologic experience of that pain, right? And this signal keeps getting put out and put out and put out. And even if that trigger no longer exists, that pain pattern is still there. So if anything contacts that area, or anything feels similarly to what caused that initial problem, patients just begin to feel it again, even though it might not exist in the tissues. Right. So I think as we work with them and encourage them and contact them hands-on, that really does help to get past some of that undefined psychological sort of experience of the pain. And they're afraid, like, if anything touches that area, or if they move in a certain area, it's going to hurt. And we try to slowly sort of get them through that.
Is that, the way you explained it to me right now, do you explain that to your patients too, verbally as well?
Yeah, okay. Depending on the patient. Some patients, I think, what we set up here is not a coddling sort of experience in the office, where I think a lot of other clinics that I've worked in, I mean, that's kind of the attitude. And I think there are motivators there that might not be so ethical. You know, if you have a chronic pain patient, that can be a patient for a long, long time. Right. And you can bill insurance for that, and so on and so forth. I do not think that that's an ethical way to go, but I've seen it. And so instead of being sort of a Band-Aid approach, like, hey, I hurt today, they come in, you feel maybe a little bit better on a Borg scale or a VAS, you know, the numeric scale, and we feel like we've done something good. And then they come back again and again and again. You're really not making any big difference. So I would say that I think with the multiple sort of aspects of treating a chronic pain patient, I think what we do here is we set some parameters and boundaries and expectations. So patient comes in, we've got a condition that we're treating, and we're going to have certain parameters at the beginning that get tested, outcomes measures, and then we're going to have a middle section where we do the treatment, and then there's going to be another re-exam where we retest those outcomes and see where the patient is as far as progressing, and then we're going to have an end point. And sometimes just having them understand that I don't expect them to get to 0 on a pain scale, that, you know, 1 is pretty manageable for somebody who's been in a 6 or 7 out of 10 pain for, you know, 8 months or something. Setting that expectation, I think, is helpful. And then to get them to realize that, you know, it's okay if they have some discomfort or pain, that it's not the end of the world, that it's something that if we really get into the discussion, it's more about, with the patient, it's more about how difficulties and challenges like this build character and give you gifts that you sort of are unexpected, right? Sure. So unexpected gift of having a lot of pain is empathy, right? I mean, that's a big part of it, right? And as far as you know, the experience of the pain, you don't really want to think about that, like, while you're in it, but sure. I think it really is a great lesson, and maybe that's a lesson that's learned for that patient, not in the next 3 or 4 weeks as they go through care, but maybe the next year or 2 years or 3 years or 4 years, I don't know. But to set that parameter and to set that expectation, I think, is important.
How do you set that expectation? Do you work with the patient, or is that something that comes from your experience? What's the process like?
Most of it is verbal in the beginning, and then we do a report of findings and talk about the expectation. And merely saying it, I think, changes the expectation. I think some patients do come in and want to be coddled, or they want to be kind of like, they want me to be available just whenever they want me to be there, and we want them on a sort of a schedule, right? We want them to be able to do their own work, we want to be able to work with them, and then we want to release them back out into the world, kick them out of the nest, whatever you want to call it. Right. And so I'll talk to them about that, and I will encourage them to do things to help themselves day in and day out. I think meditation is a great way to do that.
Mm-hmm.
I talk about the connection to, this subconscious breathing that we don't even think about, and then the ability for you to access that subconscious activity consciously by controlling breath and then letting it go. And I think that people aren't necessarily that open to that, but some of them that are kind of get it, and they're like, oh, okay, I'll try that. You can lower your blood pressure, and you can change your experience of discomfort and pain just by changing your reaction to it.
Mm-hmm.
So the trigger's still going to be there, maybe. So maybe you do have a chronic hip osteoarthritis that's just going to be a problem for a long time. But how you respond to that, I think, is really important, and that'll be stuff that I talk about while I'm treating the patient. I'll mention these little anecdotes, vignettes, whatever, and just talk about, that. And I think it kind of comes through. I mean, we've been very successful in getting patients better.
Mm-hmm.
Doesn't mean they're not going to have it again, but I forget where we were going with that.
No, that's
where I was going with
perfect.
that,
No, it gives me a really good background on what it's like to be treating them. And by the same token, it seems like they're pretty responsive to what you have to tell them and the education that you give them.
Yeah, and I think it's definitely part of the delivery as well. I mean, you have to have a rapport with the patient. You can't have a patient sit in your office and you just talk at them. You have to ask them about what's important to them. We have patient-specific functional scales, outcomes like that, where if a patient has pain in their lower back, they'll fill out an oswestry or a back survey, and then they get a score. A lot of those things are very general, but when we start talking about like a patient who has low back pain and is unable to play and unable to swing on swings with their kids, and they want to be able to do that, and that's really impacting their quality of life. And the more they can't do that, the further and further down that sort of spiral they go. And so identifying that, focusing on that, building that up, those things are really important, and that's part of the discussion as well. And I do think that it's about like making the patient feel comfortable, like not just talking at them, like and telling them what they need to do. And you also want to tell them why, like, hey, you're going to be happier with your life and your kids. Be able to be there for them and be able to play with them and do so on and so forth.
Sure. So communication is a big part of the work, it sounds like.
Yeah. Well, I'm sure in your field as well, you know that.
Absolutely.
Right? Yeah.
For me,
So
yes.
yeah. I mean, you can't just like sit there and not engage with someone and then expect them to like learn something or glean some sort of like helpful information or something.
Exactly. Now, the part about engaging and building the rapport, is that something that you were trained in, or is that something that's a part of you?
Definitely more individual than trained.
Okay.
Yeah.
So would you say outside of the work context, you have the same kind of communication skills with friends or family?
Yeah.
Okay.
Yeah, for sure. I think I've got a lot of close friends that I'm able to kind of work on stuff with and talk about life issues and past issues and things like that. Not a ton of them, but a handful, which is great.
Sure.
Yeah, I mean, it's funny just thinking about that, the survey and stuff, and seeing that like my, the parental images or the parental figures are not necessarily the ones that I go to, but definitely the friends. So that was interesting. We don't even think about that, but yeah, obviously it's there daily. I think it's more about like that personal desire, that personal awareness of like how helpful that can be. Even not necessarily dealing with chronic pain, but other sorts of trauma or other sorts of emotional pain. I think it's very similar. But here in this instance, or in these scenarios, in these offices, we have people who also have like tissue damage. And so there's a specific thing we can do to heal tissue, and it's time dependent, and it's got some parameters around it. And then on top of that is the connection to that. So people who come in and they're in chronic pain, I find, depending on we have these diagrams, the body charts, and you can really see clearly like people who have story about their pain as opposed to just an experience of pain. And you can see it when the way they draw it and how it looks and all these marks and all these arrows, and they're explaining everything. And those are really challenging patients to
What makes them so challenging?
Because they've connected so much to that story, and they want to believe that story, and they're perpetuating that story, and I think that that's a difficult thing to dislodge from somebody's experience of pain.
Do you ever notice if the story changes as they're getting better?
That's a good question. Yes and no. Okay. So some people I feel are unwilling to look at things differently, right? Mm-hmm. How many chiropractors does it take to screw in a light bulb?
I don't know.
1, but it takes 12 visits.
Oh.
How many psychotherapists does it take to screw in a light bulb? 1, but the light bulb has to want to change.
Yes.
Right. So you have to have someone who's actually interested in changing that connection. Uh-huh. And if they're, and I can't tell you exactly how I figure that out or how I see that in a patient. Mm-hmm. Usually it's pretty clear after the first couple times that it's not necessarily going to work out. And I'll tell them that, and I'll say, I don't think this is the best fit for you, and why don't we, refer you to someone else, and maybe it's something like acupuncture, or maybe it's something that more, energetically kind of changes things. Sure. I think maybe that's what some people need, because they can't think their way out of it, because they think themselves right back into that story, instead of changing their mind about the story. And I think if they have an excuse, like something that's kind of undefined, acupuncture or something like that, will really push them over, and they'll finally start to see that, oh yeah, I do feel better. And I think that's my own take on that. I don't think that's something we've talked about even here in the office, but and I have seen people change their story and start to see it differently. Like, when someone comes in with chronic headaches and they're trying to fight it all the time, and then they kind of give into it and say, you know what, my body just needs to take a break. Right. And they start to listen to that, and then they get the rest they need without, getting to a state of anxiety or a state of like a panic about it, that they just are willing to pull the plug on the stuff that they plan to do that day and be able to take care of themselves. And I think that's pretty powerful. And the changes, like, hey, I'm doing this to take care of myself. I'm doing this to take care of myself. And it's like the first time they've ever taken care of themselves, and they've spent their entire lives like raising family, taking care of everybody else, and then kind of just suffering. So, pain's okay, suffering optional, right? I mean,
sounds so much like my work.
Yeah, right.
No,
totally.
Wow.
Yeah, it's so similar. And I think just the difference would be that there's just a tissue component to what we do. And some of them can be very complex, and there can be autoimmune disorders and things like that aren't easily taken care of just by therapy, but they involve some sort of tissue. But the other stuff is all the stories, all of the parental imago things that you sort of have going on in your life that you like can't quite get out of. And so I get that it's very similar, but different. So if we can help those people, chronic pain patients, to realize that we can change the tissue then will no longer give them this trigger. They have to retrain themselves to like change their connection to what has happened, and that's oftentimes done with some improvement in their sense, improvement in their condition.
Okay. I think this is kind of like a segue. So could you take some time to describe what kind of patients you relate to better, and then which ones are more frustrating? I guess I'm interested in thinking about communication styles, because it kind of made me think about when you said you would refer them out because you just don't see it going anywhere, and I think that's a pretty important thing to be aware of also, because it is such a big part of the work and how you get your outcomes. So I guess when I ask about descriptions, I guess examples of how often you like to work with a patient, not just like a duration of over time, but also what each appointment is like ideally how many minutes you like to spend with them, how much communication is too much or too little, those kind of ideas.
Sure. Yeah. I think the patients, so when we start off, we'll go through about an hour-long intake. And that'll involve neurologic screening, orthopedic testing, balance, ranges of motion, all of this basic stuff. We might do imaging, we might have a need for something else, and we talk about that in that process. And then I will basically explain to them what I'm finding on the exam and kind of talk about the way things hurt and how they hurt and what it means. You know, sharp pain is different than dull and achy, and you know, pain with movement, you know, that's active is different than pain that's passive. Like if I move you and it doesn't hurt, you move and it does hurt, then that means different things. And I'll walk them through that pretty quickly. And then we'll set up a treatment plan. Primarily, the frequency with which I treat patients is twice a week. Unless they're really acute and have difficulty walking or sitting, or, you know, these are different cases. But for the most part, it's twice a week and for about 4 weeks.
Oh, okay.
And then at the end of that 4 weeks is when we do that re-exam and check in with them. So about 8 visits, 7 or 8 visits.
Oh, okay.
And then we revisit, sort of see which direction they're headed. And I'll tell them, like, we're looking for improvement in these numbers. Like, you're going to take this sheet of paper again, you're going to answer these questions just like you did the first time, and we're going to see how it's changed. And then we point out the progression and say, like, the patient had a 28% on their Oswestry score in the first one, and now they're at an 18. So they've improved 10%. And that's really great, you know, and so we talk that up. But what we find is that if patients, you know, come in and they give us the Borg scale, which is a verbal pain scale. So how do you feel today out of 10? 10 being the worst pain imaginable, 0 being nothing. And they'll say a 5. And then the next time they come in and it's a 5. And the next time they come in and it's a 5. Like, something's not changing, right? And maybe it's the tissue damage just isn't getting better, but also, like, why? Like, why wouldn't things be changing? Are you doing everything at home that you're supposed to do? Are you thinking of this as something different? Are you know, they'll start telling me, like, more about, like, well, I have all these deadlines at work. I'm in poor positions, which is basically prolonging the tissue issue. But also they'll mention a lot of the psychological stress, and, you know, my close friend passed away and I have to go to the funeral, and, you know, all this other stuff. So we want to see some sort of progression in the right direction. And if we don't, then I don't want to spin our wheels. You know, I don't want to keep working on them if nothing's helping. So I have that, what we call the come to Jesus conversation, right? I say, well, things are getting better. We're going to sort of, like, visit with you earlier in the re-exam, and we're just going to talk about where we're at, you know? And then they'll say, like, well, yeah, I don't think it is working, or yeah, I think it is working, it's just taking longer, or whatever. So we kind of have an agreement there, like, we're in this together.
Right.
I'm helping you, but you're also helping yourself. Like, it's not all my job, right? You have to do the stuff at home. You have to be aware of what you're changing and not changing. So it really is a dialogue the whole way through. And so I think that answers kind of what the frequency of treatments would be. How long they're here is usually about an hour.
Okay.
So I'll treat them for a few minutes, and I'll talk to them as they're on my table. I'll adjust them, and you know, the sort of the manipulation of the joints and muscle work. And then they're up in the other area doing rehabilitation exercises and progressing through their ability to do that. And then sometimes they'll do passive modalities, electrical stim or something like that. And then, like I said, at the end of that 4 weeks, we'll re-examine.
Do you ever go into a period of time, like in my field we have maintenance, so, you know, there's nothing acute, but they might come in for like a bi-weekly check or a monthly check or something like that.
Yeah.
So do those adjustments apply? Are there patients who come in like less frequently but just to get adjusted, or?
Yeah, and I think some of the most successful patients are the ones that have had it for so long, like chronic pain patients. They have gotten better, and maybe they're the ones that I say, like, great for you or optimal for you would be a 1 to a 2 out of 10. Like, not a 0. Because it seems to me like it's never going to be a 0 for that patient. And what they do is then they sign on and just come in once a month. And at that point, they feel like they're taking care of themselves. I feel like I'm taking care of them. And we have like a touch point, right? We have a time where we can kind of talk about what's going on for them. And so I think it's, you know, it's sort of a support role, and just to sort of get them sort of through the next, you know, 30 days.
Sure.
And the ones who are really successful take that on. And you can't force someone to do that, right? I mean, you can try, but they'll do it begrudgingly, and it's not really right. You know, that's not quite right for them. But the people who do and they take it on, like, hey, I have to do this as part of my lifestyle, then they're golden. You know, they're really good, even though they might not be 0.
Are there patients, or do you come across patients who have unrealistic expectations?
Sure.
And what do you do?
What do I do?
Yeah.
We
How do you
have
work
the come
with
to
them?
Jesus conversation about the reality of the situation. I think really, Angela, it's about, like, to give you some background, I started running back in 2004.
Okay.
And run marathons and run 50-mile and 100-mile races. And so I'm like really energetic. I can get out there and do all this stuff. And then I have somebody who comes in and they haven't gotten off the couch in 5 years.
Yeah.
They're in pain for so much. And then I want to play volleyball. I want to get out there. And you're not going to play volleyball. Like, I don't tell them that, but like that's the attitude, is like, you're not going to do that, because if you do that, you're just going to put yourself back even further. You know, you're going to have more discomfort and pain because your body's just not used to doing that. So you have to kind of ramp up a little bit, and you know, so just changing those expectations. You know, people want to get in the gym. You know, they have a disc issue in their lower back and they want to be right back in the gym. And I tell them, if they're back in the gym, you have a really high risk of causing this to occur again. Let's give it some time to heal. Let's be gentle and kind to yourself. Take care of yourself. Let's move forward in that way. And then, you know, maybe we can get you then into the gym. So it's sort of like backpedaling a little bit, I think, is saying, yeah, it's a great idea, but you know, the reality of the situation is more like this, right? Like you can't even put your bra on in the morning and you want to go and play volleyball. That's not going to happen, right? But in a very kind way.
Does that usually help? Are they responsive, or are there patients who are still non-compliant and they try to force their way?
Oh, yeah. People just don't do whatever they want anyway, right? And some people feel, I think, you know, honest enough and open enough to come back in. And they're like, oh, I went and played volleyball and I totally screwed up my back and my neck and my shoulder. And, you know, and I'm not the type that would be like, oh, well, see, you know, I told you so. I'd be like, oh, that's unfortunate, you know, we can start over, we can take care of it again.
Does that get frustrating?
Well,
when
it does.
Can say I told you so?
But what happened? Well, no, yeah, I don't get a lot out of that, but
yeah.
I think it's important to kind of be there wherever the patient's at. You know, like patients at a certain point, and I would love them to be able to run 50-mile races with me. And the reality of the situation is that, first of all, nobody's really interested in doing that, and the other one is that they're just not ready. Like, you know, and I want them to do certain things. So we kind of want to, you know, the lowest common denominator, get through your daily life, be able to use the toilet, be able to change and wash your hair and do all that stuff. But also then, like, what's the next step up, right? So patient specific, like, can you swing on the swings with your daughter in the backyard? Maybe, no, yes, okay, and then whatever else, you know, can't bend over and pick the baby up out of the crib. Okay, well, that's important. So you got to meet them where they're at.
Definitely. Sounds like you find ways to make it very relevant to what they're dealing with.
Yeah, I think otherwise you're in a stuffy, sterile office and you're just waiting, you know, for someone to prescribe you drugs, and that's not going to help them, in my opinion.
Absolutely. It's really fascinating. I feel like I could ask you all kinds of questions. I think we covered most of the information I needed to kind of run my data, but one thing was like, do you ever cancel appointments?
What do you mean?
Just with patient appointments, do things ever come up where you have to reschedule or cancel?
To clarify the question for me, like something that comes up on my schedule and I can't be there?
Right.
Never.
Okay.
I mean, maybe twice in the past year, but that's usually like if I have something come up like a meeting and I need to leave slightly early, we try and shift the patients earlier in the day. But no, I mean, no.
And do patients cancel?
Oh, yeah, all the time. Yeah. And one of the things that I do tell them is, you know, this is what I want as far as like an optimal treatment plan would be twice a week for 4 weeks. I want you here, you know, at that interval for that period of time, and we'll have the best results. And I also tell them, you know, if they start balking at that or having questions about it, I said, look, everybody has a life, right? I get that. So try and fit this into that life, you know, and that's kind of the first test, right? Are they willing to do it, right? Like, if they're not willing to do it, like, you know, I don't know whether they're going to get better or not. So that's a piece of it. Like, their compliance is really important.
Right.
And when they're compliant, they usually get better quicker. And if they kind of do it on their own schedule, then it's like, well, not quite what I planned for you, and you're kind of still, you know, you still got the reins, and you're not listening to the advice of an expert and trying to get you there. So, yeah, and patients cancel 99% of the time if I don't see them. Like, it's not me canceling, it's them.
I see.
Yeah. Do you get a lot of doctors who cancel on their patients?
Cancels or reschedules or delays an appointment And it's interesting
Sure.
because I'm speaking with all different kinds of doctors too. So
Mhm.
it's different if you're like a pain clinic or
Sure, if you're doing injections or
exactly
physiatry or something,
things
sure.
like that. And there's
Yeah.
no relationship there really. So
There isn't, yeah. It's
Mhm.
it's with the needle, yeah.
right.
Yeah, and I think you know one of the things that Align Modern Health has done, and the guys who started this and me, is we've prided ourselves on not making you wait. Like if you wait for 10 minutes here, like we're like nuts. We're like, this patient can't wait. Like so we really want you to trust and have there's accountability there. And so if I'm asking you to do something, well, I damn well better be doing what I say I'm going to do, right? So I'll be here for your appointments. I'll get you in on time. And so I think that classic model of sitting in that sterile waiting room is really bad for people who, especially in chronic pain, right? Because they're practicing their story while they're sitting there, like waiting to see the doctor.
Yeah.
What am I going to tell them? And they're just like bolstering that whole connection to the pain. Whereas here we just get them active, right? Like, come on in, you're welcome here. Everybody has a good time. Everybody's friendly. We're going to help you as best we can. So that's been one big thing that we have here is like no waiting.
Was that part of your design? Is that what you were mentioning?
Yeah.
How did you become aware of how important that was?
There are 4 guys who started a management company that started Align Modern Health. And one of the things that they did was they came from the consumer side. Like they're consumers of healthcare, right? And what didn't they like? They didn't like to wait, right? They didn't like to just be written a script that for medication and out the door you go.
Yeah.
They didn't like that, and so that was implied or included in the beginning of making these offices. That's part of it. Like there's a couple little waiting areas, but not really. It's just a lot of paperwork, and that's on the patient. We send it out ahead of time so they can fill it out before they get there. If they don't, then sure they can fill it out here, but we don't like them to wait.
I always appreciated that too. There's like stations at the Streeterville location.
Yeah.
It's really smart.
That's funny. That's like one of our smallest offices.
Oh, really?
Yeah. Well, the Streeterville neighborhood is a little pricey, so.
It's hard to get
but
space.
yeah, it's kind of funny. Yeah.
Wow. Well, that's fantastic. Do you have a business background?
No, entrepreneurial stuff.
Okay.
I've had a couple different clinics and run some of that stuff myself. Being here is a lot better. I get to do a lot of the doctoring.
Okay.
I'm also the medical director of the clinics, so I help the clinical guidelines for all of the doctors in the offices. So I have a hand in that, and then also leadership aspect of the business.
Okay.
So
Making it consumer friendly is so smart.
yeah.
It doesn't seem like it shouldn't be so innovative, but it is.
I know, right?
It should be common sense, but you don't see it often. Is what I'm saying, I guess.
Sure, yeah, I think you're right. I think that there are, the one thing that I would sort of comment on at this point is like I remember going into Nordstrom out in Old Orchard. I live up in that area, and they have a mammogram place in Nordstrom. And I thought totally. And I thought to myself, who wants to go to some medical place or whatever? They want to feel comfortable. It's no different. Like all the protections are there. There's no radiation issue that's more risk there than anywhere else, and they're comfortable. So why not, right? So that kind of made me think about like the patient experience. This was a decade ago, but so that was kind of one of those things that it seems really far-fetched or it seems out of the norm, and yet makes perfect sense. Yeah. Right.
Great. Do you have any other comments or questions for me at this point?
Oh no, I think I've talked quite a bit, quite enough.
Well, thank you for sharing.
Yeah,
I really
sure.
appreciate
I appreciate it. Anything else?
No, that's it. That was
Great.
great. Let me just get this.
For you.